Okay, it's half past the hour. It's time to reconvene. We'll start with an introduction on dengue vaccine by Dr. Chen, who is the ACIP Workgroup Co-Chair. Dr. Chen.
All right, good morning and good afternoon, everyone. Depending on where you're sitting, let's go to the next slide. So I just wanted to, first of all, thank the ACIP members and other members and consultants that have been really seminal in our work group discussions. I also wanted to recognize that Steve Waterman, who was the former branch chief, retired, and there has been really a seamless handoff to Dr. Paz Bailey, who's the current branch chief, but really both of them facilitating the discussions of the work group. I also wanted to also give a special mention to Dr. Robert Atmar, who's the former work group chair, whose ACIP term ended, and now I'm picking up after that. So I'm trying to do justice to this. But really, nonetheless, the work group as a whole has been tremendous in trying to get through this complex issue. Next slide. So Dengvaxia itself as a vaccine, the pivotal licensure efficacy data were generated in 2015, and this resulted in the WHO's Strategic Advisory Group of Experts, SAGE, in other words, to provide the initial recommendations on the use of this vaccine. This was in May of 2016. And basically, there was the recommendation for 9 to 45-year-olds that are living in high seroprevalence areas to be vaccinated. Then in 2017, there was the disclosure of new information about this vaccine, and basically these data implied that there was an increased risk of severe dengue among persons who are seronegative prior to their first dengue prior to vaccination and then subsequent infection. So SAGE then revised their recommendations. This was April of 2018, and basically stated that there must be a pre-vaccination screening strategy formulated so that dengue seropositive persons would be vaccinated. And so in May of 2019, the US FDA has now approved this vaccine, and we here are sitting here today to deliberate on the recommendations of this particular vaccine. Let's go to the next slide. So our work group actually has a pretty long history, and I don't know if we take the prize for the longest work group, but there was an initial flavivirus vaccine work group, which was during 2016 and 17, and presented to the ACIP, in fact, at the February and June 2017 meetings. The work group then was put on hold until about 2018, and then reformed or reconvened as the new dengue virus work group. And this has been in existence since, I think, October of 2018. In 2019, during this year, the dengue work group has discussed with the ACIP the cumulative safety, efficacy, the grade, cost effectiveness, dengue diagnostics. We talked about dengue vaccination in the Philippines. We also discussed the VRBPAC review and the FDA approval of the vaccine. And moving to this year in 2020, or last year, I should say, 2020, the ACIP presented about possible phased implementation of this vaccine into Puerto Rico. We talked about some cost effectiveness analysis, economic analysis, feasibility, and questions around health equity. So now in this year, in February, we did discuss results of an independent evaluation of the dengue serologic testing and the work group's interpretation. And so today we will be navigating the evidence to recommendations framework. Next slide. So again, just to review, in February, we discussed kind of the pre-vaccination screening testing. And today we hope to talk to you about the evidence to recommendations framework. Meanwhile, we continue to talk about key messaging strategies and what messages we need to have prepared to be able to implement this vaccine, both for providers and for families, so that this vaccine can be used properly and to communicate the complexity of the decision-making process. Next slide. So in February, just to remind you, the vaccine we presented requires the pre-vaccination screening. This screening needs to be performed to ensure that we minimize vaccination of seronegative children and to maximize the ability for us to identify eligible children who can benefit from vaccination. So this requires a sensitive and specific assay. And so we recommended some certain test performance characteristics that should be included in the final ACIP recommendations. The CDC did independently evaluate a number of commercially available assays and identified 1 ELISA test and 2 rapid tests at that meeting. And we discussed the sensitivities and specificities. Next slide. So here's our agenda for today is the evidence to recommendations framework. We'll discuss some of our draft recommendations. There will not be a vote today, but in June at that meeting, we hope to be in position to have an ACIP vote on the recommendation. Next slide. So today, Dr. Paz Bailey will discuss with us the evidence to recommendations framework. I think that's the last slide. Thank you.
Thank you, Dr. Chen. Dr. Paz Bailey, will you please present the evidence to recommendations framework?
Thank you so much, Dr. Romero, and thank you for the opportunity to present to ACIP today on the dengue vaccine evidence to recommendations framework. So there are 4 distinct but closely related dengue types, and infection with the serotype provides lifelong type-specific immunity and short-term cross-immunity against other serotypes. Dengue virus is transmitted by Aedes species mosquitoes, especially Aedes aegypti and Aedes albopictus, and it is the most important arbovirus in terms of worldwide morbidity and mortality, with an estimated 400 million infections every year. Dengue fever can range from asymptomatic or mild to severe disease, and the mortality range can go from 0.2% if treated to as high as 20% if untreated. The causes of death are mainly unrecognized or prolonged shock, unrecognized hemorrhage, fluid overload, and nosocomial sepsis. The first infection with dengue is usually mild and will induce antibodies against the 3 other dengue viruses for a period of time. However, over time, the antibody levels go down and suddenly go from being protective against future infection to harmful in a process known as antibody-dependent enhancement, or ADE. And the theory is that there are not enough antibodies to effectively neutralize the virus, but there are enough to bind the virus and then help it enter into immune cells and then activate all types of inflammatory responses. ADE explains why the second infection is proven to be the most likely to lead to severe disease, as you can see in the graphic. And it also explains why making a dengue vaccine has been so difficult. If you don't have immunity to all 4 virus types, there is the possibility that you may have those low levels of antibodies that can lead to antibody-dependent enhancement. The phase 3 trials included children ages 2 to 16 in countries in Asia and Latin America. And when the results were published in 2015, there was a safety signal of increased risk of hospitalization and severe disease among children ages 2 to 5. Because of that, the vaccine was recommended by WHO for persons 9 years of age and older and to be used in highly endemic areas. It was first licensed in several countries, including the Philippines. And in 2016, the Philippines started giving it to all children ages 9 to 10 years of age. After additional testing of specimens from the trial participants and further analysis, Sanofi eventually found that the increased risk of severe disease and hospitalization was associated with serostatus, meaning if the child had previous dengue infection or not before receiving the vaccine. Going back to the graphic on the sequence of infections, if you give the vaccine to a child who hasn't been infected before, it works as a silent primary infection that does not fully protect against all serotypes. When the child gets naturally infected through a mosquito bite, they get their second infection, which is the riskiest for severe dengue. If you give the vaccine to a child who had dengue before, then you skip the second infection, and the next natural infection they get is like a third or fourth infection. After this information was released from Sanofi, WHO revised their recommendations stating that the vaccine should only be given to children with laboratory confirmed evidence of past infection. Unfortunately, the Philippines had already vaccinated almost 1 million children without doing any testing, and the backlash was huge. The suspension of the program broke public trust in the dengue vaccine and in vaccines in general. The hospitalized and severe dengue cases that occurred following vaccination were a mixture of breakthrough cases from those who were seropositive when vaccinated, since the vaccine is highly effective but not 100%, and also cases from those who are negative at vaccination. Later analysis of the data in the Philippines has suggested that most dengue hospitalizations among vaccinated children were actually breakthrough disease, and a small percentage were vaccine-induced hospitalizations. But the most important take-home message is that in the case of the Philippines, there was no screening before vaccination. The available data has shown that this is a safe and effective vaccine for children 9 to 16 years of age with evidence of a past dengue infection. The FDA licensed this vaccine in 2019 for this group of children who live in an endemic area in the United States. At the time, however, there were no commercially available serological tests that reliably determined whether a child had had a past dengue infection. And in order to determine if safe implementation of the vaccine was feasible, CDC evaluated commercially available tests to detect dengue IgG antibodies. This evaluation confirmed that there are tests available with high specificity and adequate sensitivity. And the dengue vaccine workgroup drafted recommendations on the performance of tests used for pre-vaccination screening that include a minimum specificity of 98% and a sensitivity of 75%. I would like to present now on the results of the evidence to recommendations framework. We have assessed each of the elements in the traditional ETR framework, and I will show a summary of the evidence for each element. Our policy question is, should 3 doses of Dengvaxia be administered routinely to persons 9 to 16 years of age with laboratory confirmed previous dengue infection and living in endemic areas? The first question in the ETR framework is if dengue disease is of public health importance. So in red boxes are highlighted the U.S. territories where dengue is endemic, and the last column in this table has the population in each U.S. territory or affiliated states. And this is to show that 90% of the population at risk of dengue resides in Puerto Rico. Other territories that are considered endemic areas or affiliated states include American Samoa, USVI, the Federated States of Micronesia, Palau, and more recently, the Marshall Islands. Dengue epidemics occur in a cyclical pattern every 5 or so years, and 95% of dengue cases in the U.S. territories have been in Puerto Rico. There has been an unusually long period with little dengue transmission in PR since 2014, But in 2020, dengue cases started being reported, and there have been over 1,000 PCR confirmed cases reported since the beginning of 2020. These graphs present the distribution by age of dengue cases and the incidence rate, and also of dengue hospitalizations in the blue bars. Most dengue cases and the highest incidence occurs among children ages 10 to 19. And a similar pattern is seen for dengue hospitalizations. In contrast, for dengue deaths, the deaths are mainly seen among adults, with nearly 90% of cases occurring among adults 20 years of age and older. Seroprevalence data among children is only available from Puerto Rico and not from other U.S. territories. In 2007, seroprevalence was estimated at 50%. There's also data from the phase 3 trials that Sanofi conducted that suggested that 56% of the children ages 9 to 16 were seropositive. And more recently, CDC found similar results from a survey done in 2018 among children in southern Puerto Rico, with nearly 60% seropositive among children 9 to 16, and seroprevalence at 9 years of age being 50%. So the workgroup concluded that dengue is a disease of public health importance. The next section is on benefits and harms. How substantial are the desirable anticipated effects? This graph presents efficacy against virologically confirmed dengue, or VCD, among seropositive participants ages 9 to 16 years of age. First are the results of Asia and then of Latin America. And the combined efficacy is about 82%. Efficacy varies by serotype and is higher for serotype 4, that is highlighted in the red box, at 89%. Efficacy was lower for serotypes 1 and 2 at 67% and 80% for serotype 3. Efficacy against hospitalization and severe dengue is shown here as a relative risk. And it was estimated as part of the case cohort study with 3 different methods: multiple imputation, TMLE, and NS1 testing. Based on the multiple imputation results, there is a 79% reduction in hospitalization risk and an 84% reduction in the risk of severe dengue, estimated as 1 minus the relative risk. The workgroup considered the desirable anticipated effects were between moderate to large. How substantial are the undesirable anticipated effects? With regards to the undesirable effects, the most important one is increasing the risk of hospitalization and severe dengue by erroneously vaccinating a seronegative child. So this presents the risk of hospitalization first with the 3 different ways to estimate it: multiple imputation, TMLE, and NS1. And you can see that the point estimate for the relative risk is greater than 1, suggesting an increased risk of these outcomes when vaccinating seronegative children ages 9 to 16. The increased risk in seronegative vaccinees compared to controls for hospitalizations was between 40 to 50% greater risk, and for severe dengue between 2 to 6 times as high as in the controls. The differences were not statistically significant because of the small sample size of seronegatives in the trial. For severe adverse events and deaths, there were no differences for severe adverse events at 28 days. And at 6 months, there were fewer severe adverse events among vaccinees compared to controls. There were no differences in deaths. The workgroup considered the undesirable effects to be small. So do the desirable effects outweigh the undesirable? The benefits of Dengvaxia are that it prevents symptomatic dengue, hospitalizations, and deaths among seropositive children. The efficacy against symptomatic dengue is 82%, against hospitalization 79%, and against severe dengue is 84%. The main potential harm is the increased risk of vaccine-induced hospitalization and severe disease when a seronegative child is vaccinated after a false positive result. So to assess this issue of the balance between benefits and harms, researchers from University of Notre Dame conducted an agent-based model of dengue transmission with humans and mosquitoes represented as agents, and it was calibrated to simulate dengue transmission in Puerto Rico. It compares pre-vaccination screening and subsequent vaccination of seropositive 9-year-olds to the status quo. The model population was 9-year-olds with a new cohort of 9-year-olds being vaccinated every year, and they were followed for 10 years, keeping track of dengue infections, hospitalizations, and deaths. And I will mainly present results on two scenarios of 50% seroprevalence and 30% seroprevalence. The population level benefits were symptomatic and hospitalized cases averted, and the risks are vaccine-induced hospitalizations among seronegative individuals. Using a test with a 75% sensitivity and 98% specificity, the model estimates baseline symptomatic and hospitalized cases among the entire population. And then among children 9 to 16, the number tested and vaccinated, symptomatic cases and hospitalizations averted, and the number of additional hospitalizations by erroneously vaccinating seronegatives with a false positive test result. And I will present the same numbers that you see here for the 30% and 50% scenarios in a graphic. So in a scenario of 50% seroprevalence, more than 4,000 symptomatic dengue cases would be averted and nearly 3,000 hospitalizations. There would be 51 vaccine-induced hospitalizations among dengue-naive children or seronegatives vaccinated after a false positive result. In a lower seroprevalence scenario of 30%, over 1,500 symptomatic dengue cases would be averted and over 1,200 hospitalizations. There would be 112 vaccine-induced hospitalizations among seronegative children vaccinated after a false positive result. So in summary, the population risk of a screen and vaccinate strategy over 10 years in a 50% seroprevalence scenario are 51 vaccine-induced hospitalizations, and the benefits are over 4,000 fewer symptomatic cases and nearly 3,000 fewer hospitalizations. In a lower seroprevalence scenario, 122 vaccine-induced hospitalizations among seronegative children, and their benefits are over 1,500 fewer symptomatic cases and over 1,200 hospitalizations prevented. The workup interpretation of the benefits and harms was that there was a positive balance for benefits versus harm, and that this balance varied by the seroprevalence among 9-year-olds. The workup interpretation was that the balance favored the intervention. We evaluated the certainty of the evidence following the GRADE methodology for the outcomes of virologically confirmed dengue, hospitalization, severe dengue, and death. And the certainty was considered high for efficacy and moderate for safety. The next question is, does the target population feel that the desirable effects are large relative to the undesirable effects? And to answer this question, CDC conducted a survey in Ponce, Puerto Rico, and found that 75% of parents said that they were interested in vaccinating their children with a hypothetical dengue vaccine if the vaccine was provided for free, and 68% if they had to pay for the vaccine. For those unsure or who would not vaccinate, that were a total of 342 out of the 1,139 participants, side effects was the number one concern. And the workgroup interpretation was that probably yes, that the population felt that the desirable effects are large relative to the undesirable. Is there important uncertainty about or variability in how much people value the main outcomes? The workgroup considered there was probably important uncertainty or variability. Is the intervention acceptable to stakeholders? For this, the University of Georgia conducted a survey among 109 physicians in Puerto Rico and showed that half, or 56%, were familiar with the vaccine. And after describing the need for screening before vaccination, 72% said that they would recommend the vaccine if there was a test with acceptable specificity. So the workgroup interpretation was that probably yes, the intervention was acceptable to key stakeholders. So in terms of feasibility, is the intervention feasible to implement? Implementation of vaccination for Dengvaxia will be more challenging than for other vaccines. 3 doses are required. Extensive education of providers and parents will be needed. The vaccine costs will be covered by the FC or insurance, but there still will be out-of-pocket expenses because of the repeated visits. This is the first vaccine that will require screening before vaccination, and it is not something that is needed for any other vaccine. For screening to be conducted safely, the first step is to have tests available with good specificity. Determining if tests were available was one of the workgroup priorities. And after the CDC-led evaluation that I mentioned, we did identify 2 versions of a rapid test and an ELISA test with high specificity and moderate sensitivity. Implementation of point-of-care testing in Puerto Rico is challenging since only laboratory technicians can conduct testing. None of the tests with adequate performance have FDA approval. Puerto Rico laboratories have experience implementing non-FDA approved tests under Clinical Laboratory Improvement Amendment or CLIA protocols and can provide results to participants. We have had conversations with insurance companies and Medicaid on who will cover the cost of the test. And what we have learned after those meetings is that they will cover the test if there is a routine ACIP recommendation. If the recommendation is shared decision-making, they may require proof from providers that the test is needed before reimbursing the cost, so potentially additional paperwork. The screening before vaccination will result in additional visits to the pediatrician office, the laboratory, and the vaccination clinic that affect feasibility. The dengue vaccine workgroup developed guidance on test performance for pre-vaccination screening. And if there is an ACIP recommendation, this guidance will be published as part of the MMWR that accompanies the recommendation. The guidance includes that tests should have a sensitivity of 75% or greater and a specificity of 98% or greater. Also a positive predictive value greater than 90% and a negative predictive value of 75% or greater to minimize missing persons who would potentially benefit from the vaccine. The workgroup also considered that sequential testing using a 2-test algorithm could help improve specificity. It is currently challenging to think about a 2-test algorithm with the limited number of tests available, but it may be an option in the future as more IgG tests become available. A communication plan will be a key component of the implementation of this vaccine and will include counseling messages for providers on how to communicate the risks and benefits of the vaccine. And I just wanted to show you some draft examples of these messages that we have been validating with a series of focus groups first with workgroup members, then with dengue clinical experts in Puerto Rico, and we have had a third focus group with pediatricians and general practitioners. So in terms of communicating the risk of disease, the message would be that dengue is common in Puerto Rico. The risk of getting dengue more than once while living on the island is high, with most people getting dengue two or more times before adulthood. Second, dengue infections can be more dangerous and require hospitalizations. However, any infection can be dangerous. The benefits of this vaccine are that in children who have previously been infected with dengue, the vaccine protects against illness or hospitalizations caused by dengue 8 out of 10 times. Some people can still get dengue after vaccination, and this is called breakthrough infection. There are risks associated with this vaccine in children who have not already been infected with dengue. The vaccine can increase the risk of severe illness and hospitalizations if the child gets dengue after vaccination. And the risk is similar to what a child faces when living in an endemic area and being naturally exposed to dengue multiple times. So how do we reduce this risk? To reduce the risk of vaccinating children who have never had dengue, a laboratory test for dengue is required. However, no test is 100% accurate. There is a chance that 3 in 100 children who test positive might not have had dengue before or have a false positive result. So we're still in the process of finalizing these key messages, but I wanted to show you that we have been having a lot of progress in this area. So the workgroup interpretation was that probably the intervention was feasible to implement. So is the intervention a reasonable and efficient allocation of resources? This graph comes from the cost effectiveness modeling from University of Notre Dame and shows the incremental cost effectiveness ratio, or ICER, in the y-axis for each of the graphs by the cost of vaccine on the x-axis. And they're showing two seroprevalence scenarios, 50% seroprevalence in red and 30% seroprevalence in black. I'm showing here the ICERs for QALYs gain, for averted symptomatic infections, and for averted hospitalization. And the ICER can be interpreted as the cost of the intervention minus the cost of hospitalization and treatment for each QALY gain, for example, or for each symptomatic case or hospitalization averted. So a lower ICER indicates a more cost-effective vaccine. The ICER goes up with lower seroprevalence and a higher cost of the vaccine. At a seroprevalence of 50% at age 9 and an estimated cost of the 3 doses of the vaccine of $382, the ICER is estimated to be $122,000 for the 50% seroprevalence, and for the 30% seroprevalence, the ICER is estimated at $240,000. So I know this is hard to follow, but just to put this ICER into context, I am using a graph from a review paper in pediatrics of the ICER for other pediatric vaccines, and vaccines are ordered here from the least cost-effective with the highest ICER to the most cost-effective with the lowest ICER. So the 3 doses of dengue vaccine are shown in red bars for 30% seroprevalence among the least cost-effective vaccines at the top of the graph, and for 50% seroprevalence further down below the graph. So is the intervention a reasonable and efficient allocation of resources? The workgroup judgment was between probably yes and yes. So in terms of the impact on health equity, there are marked disparities between Puerto Ricans and other U.S. citizens in healthcare. Puerto Rico has the lowest Medicaid and Medicare per capita annual spending. Mosquito-borne diseases are highly prevalent, and in addition, PR has repeatedly suffered natural disasters like hurricanes and earthquakes that affect the risk of vector-borne diseases. The work group discussed the following considerations so that the use of Dengvaxia helps reduce health inequities. Health insurance and Medicaid should cover for the cost of the laboratory test. The cost of the test should be minimal and funds available for those who are not covered by insurance or Medicaid. Multiple visits to the pediatrician, laboratory, and vaccination site will be challenging and may be a larger burden for low-income families because of transportation costs and missed days of work. So strategies to reduce the number of visits would be needed to reduce the impact on health equity. The work group considered that the use of the vaccine would increase health equity. In terms of the balance of consequences, the work group considered the desirable consequences probably outweigh the undesirable consequences in most settings. And the work group also considered that there was sufficient information to move forward with a recommendation. So let me stop here and answer some questions before moving to the type of recommendation.
Thank you very much, Dr. Boss-Bailey. So as hands go up, let me ask several of the questions that I have. So first of all, under vaccine, interest in the vaccine, when the parents were questioned about their interest, was it understood or was part of that information that was provided to them the need for the testing prior to the vaccination? Second question, you list the key stakeholders as the physicians, but it really isn't the physician who's the key stakeholder, it's the parent who is, and I wanted to know why that was done. And lastly, you give us a cost analysis based on $2,006, and we're in 2021. So, why wasn't an adjustment done to consider that? So I'll stop there. I have more, but there are many more hands coming up. So I'll turn that over to you now. Thank you.
Thank you, Dr. Romero. So I don't know if I'm going to remember all your questions, but let me start by answering the question on the stakeholders. We have been sort of studying who the key stakeholders are going to be to implement a vaccination program against dengue in Puerto Rico and to implement it well. And there are different associations of parents and different associations of physicians. We also want to work with the Tecnólogos Médicos and with other healthcare providers, and of course with the municipalities and the government and the media. We are mapping all the stakeholders. What we have been learning is that clinicians are a very important group because they are the ones that are providing information to parents on the benefits and risks of vaccination, and they are the ones who the parents trust. So I just showed as an example the counseling messages that we're working to be able to provide to providers so that they can communicate this vaccine clearly. But we're also working on messages for families and for the public. With regards to your question about how this question was asked from as part of the survey in Southern Puerto Rico, we asked about a hypothetical dengue vaccine and did not go then into the specifics of having to screen before vaccination. However, we have done additional focus groups and formative work where there is more of a chance of a dialogue and explaining the complexities of the need to screen and only provide this vaccine to children who have had dengue before, because it can sound very confusing. And as part of those forums and those conversations, we have learned that parents would accept the vaccine if properly explained and if enough information is provided, and that clinicians and pediatricians are seen as the most trusted source of information. And then with regards to the cost effectiveness analysis, this was using 2008 dollars because it was the latest survey available comparing, presenting hospitalization costs. But we can, we have been working very closely with the University of Notre Dame. They have kindly reviewed the model to provide additional data on a higher specificity and sensitivity, so we can consult with them to see if there's an opportunity to update the model with more recent cost estimates.
Thank you very much for those answers. I greatly appreciate them. Dr. Fry, you've been waiting patiently.
Thank you. That was a great presentation. Thanks so much. I had a couple quick questions. I was just wondering, so the vaccine is supposed to be given to folks who have already had at least one exposure to dengue. I was wondering if we have any sense of the number of cases of breakthrough after a first or second vaccine, and if those cases were less in severity had they not received the vaccine. My other question briefly is, the ELISA test or whatever test is being done has a sensitivity about 75%, which is good, but it's not great. So as far as liability, I guess, and adverse events, and I was just curious, who pays for that? Is there a mechanism? Does the country have or do we have a mechanism for paying people if they had, for example, an adverse event to the vaccine, or if there was an adverse event because the test was not up to par, for example? Thank you.
Yes. So regarding the question on breakthrough infections, so there. The vaccine is only about between 70 to 80% effective. And there is some additional data on the efficacy between the first and second dose and the second and the third dose, and efficacy was similar. So and Sanofi may comment on that since they're on the call, but I think there are plans to submit to FDA for a simplified schedule. But just going back a little bit to this issue of the breakthrough infections, as part of the experience in the Philippines, there was some mathematical modeling done to understand in that situation of 80% seroprevalence among the cases that were hospitalized and reported a history of vaccination, what percent were due to breakthrough infections and what percent were due to vaccinating seronegatives. And they found that about 60% of the hospitalizations were due to breakthrough infections and 13% were sort of vaccine-induced hospitalizations. In terms of the clinical presentation, I think it is not possible to determine, which cases are because the vaccine was not effective. But the comparison that the phase 3 trials have allowed to show severe presentation of severe cases among vaccinated seropositives and vaccinated seronegatives show that the presentation is very similar, and there were no significant differences in the percent presenting with hemorrhage or the percent presenting with plasma leakage. The one difference was in the prevalence of organ involvement that was more common among seropositive participants than seronegatives. I hope I did answer your question there.
Thank you.
Dr. Long, please.
Golly, this is so difficult, and we have been prepped with a prior session just so we would get a little bit up to speed on this, but I don't think I'm cured of some questions, wonderments, concerns maybe from all of this. So as I sort of simplify this is an attempt to replace a second infection with dengue with a vaccine experience because the second infection, which I think you told us was usually due to a different serotype, was more severe than a primary infection. And having understood that, I'm a little bit concerned now since the lack of endemic disease since 2014 to understand if the vaccine itself, maybe even in those who were seropositive, replacing enough or causing enough antibody or whatever kind of complete response that prevents the next episode. It's not the vaccine that causes severe dengue in those that were naive. It's that they get an episode of real dengue and they respond in a severe way. So I guess my questions are, number one, since 2014 and there hasn't been much around, has this been studied carefully since that time? I lost track a little bit of the times of study. And is it possible that the antibody signature after vaccine, in the absence of repeated or soon after infection, when it was more prevalent, would again revert to that low antibody and the possibility of antibody-dependent enhancement? So I guess it's a whole bunch of questions in one, but I think you know where I'm going. And have children who've received the vaccine who were previously seropositive been followed long enough in this lull in dengue to have them get an episode and know 4 years later that they're not that they're in trouble again?
Yes, thank you, Dr. Long, for that question and also for summarizing some of the sort of the rationale. But basically, the Vaxia does not provide balanced protection against all 4 serotypes. It is mainly a vaccine against dengue 4. So this is why it cannot be used among dengue naives. It would need to provide protection among all serotypes to prevent the resulting effect of antibody-dependent enhancement if someone gets vaccinated and then naturally infected by a mosquito. What we know from studying dengue without the vaccine is that there are cross-protective antibodies that are generated after a natural infection, and those last about 2 years. And then after 2 years, then we can see ADE occurring. And the longer the separation between the first and the second infection, the more likely it can result in severe dengue. So infections that happen closer to each other are less likely to result in infection than infections happening, let's say, 10 or 20 years later. Those are more likely to result in severe dengue. But this is sort of with natural infection. So regarding the vaccine, Puerto Rico was one of the sites for the phase 3 trials, but there were multiple sites in Asia and Latin America. And the children have been followed. And what we know so far, based on the data that Sanofi has shared with us, is that protection against hospitalization is still present in year 5 and 6 after vaccination. And that protection is still effective. So I wouldn't be able to answer what happens later, but what we know, at least so far, is that in year 5 and 6 of the trial, the vaccine was still efficacious against hospitalization.
And just to ask you a simple question about that, thank you so much. Were those other countries places where dengue is more prevalent than in Puerto Rico right now, where you could have anticipated that there are frequent reinfections and frequent boosting or fleshing out of the antibody response that wouldn't allow this antibody-dependent enhancement to occur? So are you comfortable that the 5 years out in other countries is translatable to Puerto Rico in the current density of infection in Puerto Rico?
Because of what we know about the immune responses against dengue and how the vaccine is working as a silent secondary infection, the expectation is that it will provide sort of longer term protection. But I don't think that they have looked at the data for areas with higher force of infection versus lower force of infection, since the numbers of hospitalizations are small. So they have had to pull the data to get to this question about duration of protection.
Thank you. I'm going to put my hand down, Dr. Romero, so others can query, but I do have additional questions if we have time. Thank you.
Very good, thank you. We'll come back to you. Dr. Lee.
Thank you. Can you hear me?
We can.
Oh, perfect. Thank you. My question is somewhat related. So I'm trying to think about how the pretest probability would impact the positive predictive value and our ability to know who would be, optimal in terms of thinking about benefits, risks, vaccination. In terms of looking at the epidemiology, it seems very dynamic, which I think is the challenge. So perhaps children who are, on the younger side might not have had as much exposure to dengue in the past. And my question really relates to how can we account for the dynamic sort of prevalence in the background and the age of the child to understand how reliable that test will be for us to make sure that we're vaccinating the right people. And is there been any thought to thinking about how to give that information back to clinicians or at a country level to make those recommendations dynamic? I recognize how challenging that is, but maybe it's a certain threshold of acceptability in terms of that positive predictive value, since it's dependent on the pretest probability. So that's one question. And then the second question I have is, and I realize this is more of perhaps a clinical consideration rather than affecting the recommendation, but what I don't know is if they're in the midst of a vaccination series over the course of a year, what happens if they get an infection in the midst of that, and how would that impact what you would recommend going forward?
I'm not sure I understood the second question, but let me start with the first question. So dengue is indeed dynamic, and part of the reason why we have not had dengue for such a long time in Puerto Rico is likely due to the Zika epidemic and the fact that they're very closely related viruses, and that it probably provided some cross protection for dengue. And as I mentioned, we have started to get cases in 2020. We are concerned about an outbreak occurring this year, and it has mainly been dengue 1, that is the virus that was responsible for the large epidemic in 2013. With regards to the performance of the test, we have mainly focused on the 30% and 50% seroprevalence scenarios that we think likely in Puerto Rico, because of the data we have collected, seroprevalence at age 9, that would be the age to start vaccination. The FDA license is for ages 9 to 16. So based on the specificity that we have recommended of 98%, the positive predictive value would vary between 97% and 98%. For other territories where seroprevalence may be lower at age 9, such as USVI, again, we increase the specificity sort of with that scenario in mind, because for the international target product profile, they're suggesting a 95% specificity. But considering that some territories may have lower seroprevalence, we've increased the recommended specificity to 98%. And even in a 30% seroprevalence scenario, the PPV or the positive predictive value would be between 94% and 95%, more or less. And Dr. Lee, if you could be so kind to repeat your second question, because I didn't fully get it.
I'm just thinking about somebody, so presumably we would know they were vaccinated, and then they start, they had a prior infection, they start their vaccination series. In the midst of that vaccination series, they happen to have breakthrough dengue. What would the recommendation be to continue or complete that series? Would it change in any way?
Yeah, I don't know the answer for that. And we did invite our colleagues from Sanofi to participate, and maybe they have an answer. I don't know if Dr. Diane is on the line. Dr. Romero, if that would be okay with you?
Yes. Is someone from Sanofi here that can address that question? Please go forward.
Yes, this is Dr. Diana at Sanofi Pasteur. Well, in that situation, I think we would still recommend to complete the vaccination schedule. We have shown that even 1 or 2 doses are effective, and I was listening to the prior question. So the effectiveness or the efficacy of the vaccine after 1 and 2 doses, 2 doses is about 80%. So in an outbreak situation, we could potentially have this 2 doses schedule, and this information has been published already, and we could, I think, protect them. But still, the recommendation is still 3 doses, but in an outbreak situation, I think 2 doses could potentially work. And this, again, this information has been already published. I don't know if that answers your question.
Yes, I mean, I'm just thinking ahead, but I don't think it would impact necessarily this initial discussion.
Right. And by the way, since I'm here, I just wanted a prior question. There was a prior question in terms of the risk in the population in Puerto Rico, where the seroprevalence may be a little lower compared to other endemic areas. And we had some data by country from our efficacy trial in Latin America, and the relative the hazard ratio was really similar in Puerto Rico compared to other countries. So we didn't see any increased risk in that particular setting compared to other areas where the prevalence was higher. So that is reassuring. And also, as Dr. Pasquale mentioned, we didn't see an increase in the hazard ratio over time. So we look at the data by year after the vaccination, the initial vaccination, and we didn't see an increase towards the end of the study. So the increased risk occurred in the seronegatives, and as Dr. Pasquale mentioned, it was towards that second, third year where the antibody titers start to decay, but we didn't see an increase in the long term, not even in the seronegatives, but in the seropositives.
Thank you. Dr. Paling?
Yes. So first of all, thank you very much, Dr. Pasquale, for a great presentation. I also want to thank everybody for asking questions. The work group has had enormous number of meetings and discussions reflecting the complexity of this. I wanted to provide 2 thoughts. One is what I've learned through the work group is that while the risk for severe disease is greatest for the second infection, that severe disease can occur to the 3rd or 4th. So even if someone's had 2 infections, full vaccination is probably recommended. The second thing I've done is I've gone back to look at the Notre Dame study to try to answer your question, Dr. Romero,
And the Notre Dame study estimated that the ISR cost was somewhere between $68,000 and $161,000, and that appears to be in 2019 dollars. So thank you.
Thank you. Dr. Long.
Yes, it's a question about both about preventing the burden of severe dengue overall and of equity as well. So the first is kind of an implementation question. So you're testing everybody, and maybe you're finding that 50% are seropositive or 30% are seropositive and are vaccine eligible. What happens to the rest of those? You still anticipate that they will have their first dengue infection, and then they will be susceptible and potentially the beneficiary of vaccination. So would you then implement Q every year sero tests on these people to try to find more people then who have seroconverted that you would be concerned might get severe dengue with the next episode? How is that going to go down, and how would record keeping work? And attached to that is an equity question, which I don't think I could have heard it right. So this is a vaccine that will be out-of-pocket expense for most or all individuals and will be given mainly in private physicians' offices. I guess I don't understand the healthcare system in Puerto Rico well enough, but what happens to poor children? Thank you.
Yes, thank you for those questions, Dr. Long. So regarding to the continuous risk and the need to do repeated screening, we have discussed with the work group that probably we would do screening every 2 years, also considering the epidemiology of dengue and the fact that it happens in outbreaks. So you may have periods without transmission and then transmission again. So the idea would be to potentially screen children in the right age group every 2 years. In terms of record keeping, there is an arbovirus surveillance system and a database that CDC supports the maintenance, but it's the health department is responsible for it. And all dengue test results are kept in this surveillance system. There is an immunization registry that currently does not speak to the arbovirus surveillance system. So there would need to be logistics related to how we keep the information on the test results in the immunization registry. And if it's possible for the two surveillance systems to speak to each other. So we don't have all the answers on how that is going to work, but we have started understanding how the immunization registry works, the fact that there are some open fields where the result of the test could be recorded, and just started to brainstorm on how we could make the two systems talk to each other. In terms of the cost of the vaccine, I'm sorry about the confusion. My comments on that may have cost, but we have been concerned about the cost of the test and who would cover for the cost of the test, since there is no precedent for screening before vaccination. The cost of the vaccine is going to be covered, as for other vaccines, by BFC for those children under BFC and by the insurance companies for the kids that have insurance. So it would work the same as in other parts of the U.S. The cost of the test, as I was saying, we did have discussions with the insurance companies, and they sort of reassured us that they favor preventive services, that they understand the benefits of having a vaccine for dengue as opposed to covering the hospitalization costs, and that if there was an ACIP recommendation, they didn't have any problem in covering the cost of the test. So for families without private insurance, it would be Reforma, that is the public insurance here, and Medicaid. But the cost of the vaccine is covered through the sort of normal channels with BFC and insurance companies.
And thank you so much. And do I understand then that the cost of the testing for children also would be under VFC and covered somehow?
Yes, VFC would not cover for the cost of the test. And this is why we have been having the discussions with the large insurance companies. It would be the insurance company that would cover the cost of the test. And for those children vaccinated under VFC, it would be Medicaid.
I see. Okay. That's very helpful. Thank you very much.
Dr. Daly, and also let me open it up to any of the liaison members and ex officios that wish to ask questions at this time. So Dr. Daly, please go forward.
Thanks so much. I think, we all recognize that the epidemiology of many of the diseases that we're trying to vaccinate against change over time, and that might change the risk-benefit calculation. But it feels like this particular circumstance is even more prone to changes in risk-benefit based on changes in the epidemiology and seroprevalence. So would it be possible, if this comes to a vote in June, and if the vote proceeds as favorable, would it be possible to explicitly reevaluate the ETR more formally 24 months from when that recommendation was made?
Hi, Matt.
Yes. Thank you, Amanda.
This is Amanda. Hi. I was just going to say, yes, we have made recommendations in the past that we have said we would come back, particularly with pneumococcal, and reevaluate. I don't know that 24 months, to be honest, is long enough to really monitor for trends and really look at changes. I think that we can certainly, we're always reviewing epidemiology and reviewing our recommendations, but I think finding that, we'd have to think further about the timing of a potential formal review. Gabrielle, do you want to add anything to that?
No, thank you. Thank you for stepping in for that. But I also just wanted to mention that what we know is that with temperatures rising and with increased travel and connectivity, that the incidence of dengue has been increasing worldwide. And I think that we did see sort of an alteration of that increasing trend because of Zika. And as I mentioned, the cross protection that may be providing. But in 2019, there were huge outbreaks in Latin America, sort of suggesting, that dengue continues to be a large threat. And Puerto Rico was sort of safe in 2019, but as I said, we're seeing the increases now and expecting a large dengue outbreak during the mosquito season.
Okay, yeah, thanks so much. And Dr. Cohn, that's helpful. 24 months was arbitrary, and that might be too soon, but you can see where I was going. Thank you.
Thank you, Dr. Maldonado.
Yeah, thank you, Dr. Paz-Bailey. This has been really helpful. And, as we've been discussing this for a few years now, I guess I just wanted to follow up. I agree with Dr. Daly's comments. I do think that the changing epidemiology of dengue, it is a volatile landscape, and it would be really helpful for us to see just the landscape of an overall landscape of the epidemiology of dengue disease in Puerto Rico specifically, given that that's the one location where we will have some influence potentially in impacting the disease. So seroprevalence over time you've presented, but also serotype prevalence if you have that data over time, given that we can't look too far into the future, but obviously looking back and seeing patterns of serotype prevalence. Because I do worry that the ICER will change depending on the epidemiology of the disease. And again, I know I sound like a broken record, but I really still want to make it clear that we'd like to really get more and more updates about availability of appropriate testing with each of these presentations. Thanks.
Thank you.
Thank you. Dr. Long.
You're still calling on me, Dr. Romero, so I'll keep asking. You can stop calling on me whenever you want.
My goal is not to impede questions and discussion, so I will take as many questions as you have.
Well, thank you so much. So this question is about what's going to have to be kind of a reverse message to doctors. So usually doctors look at immunization records and say, oh, you didn't get this, you need this. So although you're going to try to find a way for your systems of antibody testing and this and that to implement, it is going to be a trick and a challenge to make the very first requirement for eligibility to be seropositivity and not absence of the vaccine. And the second, I've already forgotten. It probably wasn't important. I'm going to let it go. Thank you.
Yeah, yes, Dr. Long. I don't think I have all the answers on how that would be done, but it's sort of counterintuitive. That is not, just offer the vaccine if you see that the child hasn't been vaccinated, but do the screening and then find out eligibility and then offer the vaccine. So there is a lot of discussion with providers and education of providers that needs to happen. I just want to mention that physicians in Puerto Rico are really well aware of dengue and how complicated it gets during an outbreak and how, the healthcare system really gets overwhelmed. And there are regular dengue clinical management training, so they do understand sort of the complexities of the immunological response and the 4 serotypes and sort of the epidemiology of dengue in the island. So I agree with you 100% that we need to work on education of providers and the logistics of how these reminders will be coming up on assessing eligibility before offering vaccination. But what we understand so far is that clinicians are receptive to having a dengue vaccine because we don't have any other tool against dengue right now. Vector control, we still don't have a way to control mosquitoes. And a large percent of clinicians in the island, I think, have been following the vaccine development. So I really appreciate your comment, and I think that is going to be sort of a complicated task, but I think we have sort of fertile ground for collaboration with the medical community.
Thank you. And the other complicated task, as I see it, will be a safety with a lowercase s in a bigger world. It's not so much the safety of what this vaccine might do to the host in reactogenicity, et cetera, but it will have to be safety over years. We usually like, clustering of cases around a vaccine. No, this would be safety as you then see children get dengue or you follow them a year or 2 or 5 years out. I think that to see that their next episode is not more severe. So the challenges are enormous, but you're right, the problem is enormous, and this is a big start. Thank you.
Yes.
I'm going to be quiet.
Thank you, Dr. Long. And I do think, that VARS and the adverse event reporting system is something that we will have to rely on if this vaccine is implemented. And I think that there are lots of lessons learned from COVID on how robust the system is, even to identify rare events and how important it is to communicate what we're finding in real time.
Thank you. Dr. Goldman.
Thank you. I just want to make more of a comment observation, dovetailing on Dr. Long's comments. I don't see the antibody testing so much as a challenge as an opportunity. I find with a lot of vaccine hesitant patients who are convinced, even like for the shingles vaccine, that they've never had chickenpox, testing the antibodies while not in the guidelines does help to convince them that they did have chickenpox and they do in fact need the vaccine. So logistically, it will take some education, but I think this could also be an opportunity to look at maybe incorporating antibody testing in other vaccine strategies to help overcome some of the hesitancy or concern with vaccination. That being said, in South Florida, certainly we're not a stranger to dengue either, being so close to the Caribbean and islands, et cetera. So I really think this is a good opportunity to use the antibody testing strategy. And I think for those of us in the vaccine space who are having a good vaccine program are quite comfortable testing the antibodies and can be used as resources for education. Over.
Thank you. Dr. Daly.
A comment and then a question. The comment is just to echo what Dr. Long said. It was such a critically important comment that she made about safety over the long term. Our systems are still better designed to look at vaccine adverse events that occur soon after vaccination, and that studying vaccine safety over the long term is a very different endeavor and much more challenging. The question is related to what we're doing to minimize risk of false negative tests, because the implication of a false negative test is that somebody doesn't get offered a vaccine that could benefit them. We talked about this a little bit, I think, in prior sessions, but Dr. Paz Bailey, I wonder if you could talk a little bit more about that scenario and play that out for us and how we can minimize that risk.
Yes, and point well taken about your comment and Dr. Long's, that is not sort of the traditional adverse event that we're going to see in the short term after vaccination. But we do have a good surveillance system for dengue since it's such a huge problem. And there is some underreporting of hospitalizations and severe dengue that we will need to work with clinicians and hospitals to try to improve. So that's a good point. Regarding sensitivity, we have been mainly concerned about specificity, right, and not erroneously vaccinating seronegatives. But you are totally right that sensitivity is also critical. And the problem is that when developing these tests, if they increase specificity, the sensitivity suffers, right? So that's why the recommendation has been for higher specificity and lowering sensitivity to 75%. But ideally we would have a test that is highly sensitive and highly specific, but we're not there yet.
Thank you.
And so the only...
go ahead, Dr. Go ahead, Dr. Daly.
Dr. Paz Bailey. Yeah, so then the implication for those, and I understand that it's because you're choosing, in developing these tests, there's a threshold, and you choose that threshold to maximize specificity at the cost of sensitivity. So I appreciate that, but the implication for those individuals, I think, is they test false negative today, they don't get offered vaccine, and then they may be re-screened 2 years from now. If they screen positive at that point, then they might be offered vaccine at that point. That's sort of the only pathway for them to get the benefits of vaccination, correct?
Yes, that is correct. And I don't know how likely someone is a false negative today and you're using the same test, maybe they will still test negative later. So, but
unless they get exposed, to dengue.
Yes, and have higher antibody levels.
Right. Thank you.
Okay, seeing no more hands up, we'll move on to the next presentation, but not before we thank you, Dr. Paz-Bailey, for that excellent presentation and for taking the time to answer those questions. So go ahead on to draft recommendations, Dr. Paz-Bailey.
Thank you, Dr. Romero. Sorry. Here we are. So the work group considered the policy options in the evidence to recommendations framework of ACIP does not recommend the intervention. ACIP recommends the intervention for individuals based on shared clinical decision making. And then the routine recommendation, or ACIP, recommends the intervention. And we had a lot of discussion about the different options, and I would like to share with you some of the considerations from the work group. So in terms of the option ACIP does not recommend, the cons are that a vaccine proven to protect persons with prior dengue infection is not going to be available to U.S. citizens. And it also puts off making difficult decisions that may be needed for future dengue vaccines approved by FDA. But in terms of the pros, it would avoid a complicated implementation in the middle of COVID vaccination program. The other two options are a routine recommendation versus shared decision making. And we went through different attributes that we consider important. So in terms of the impact of the recommendation on the reduction of dengue transmission, it would be unlikely for the vaccine to have an impact on dengue transmission, since it mainly reduces disease and severity of disease, but doesn't prevent infection. In terms of reduction in disease burden, the model that I presented to you estimates that of all dengue hospitalizations among all age groups, about 6% will be averted in a 10-year period with 80% coverage of the screen and vaccinate strategy and the 50% seroprevalence scenario. And with shared decision-making, there would be no measurable benefit in reducing hospitalizations. In terms of harms, the balance that I shared with you is that for every 57 hospitalizations prevented, one additional hospitalization could occur or would occur due to the vaccine. With shared decision-making, coverage would likely be low and among a selected group of patients, so potentially adverse events would be unlikely in terms of vaccinating seronegative. In terms of the cost, with a routine recommendation, coverage of the screening test and the vaccine by insurance companies and BFC Medicaid would be achieved, and it minimizes cost to families. As I explained, with the shared decision-making, insurance companies were less certain about covering the cost of the test without documented medical indication by a provider. So the vaccine would be covered. The coverage of the test was a little bit uncertain, and possibly there would be higher out-of-pocket expenses for families. In terms of implementation and feasibility, with a routine recommendation, there would be greater engagement from health departments with territory-wide policies that would lead to greater coverage, and there would likely be a greater push to solve the information systems connectivity that we discussed and the testing and logistical challenges. The health department could centralize testing at a reference lab, facilitating access to testing and the logistics of providing results back and consider a phased implementation. And it would remove some of the burden of testing and vaccination from providers and on making those decisions. It may lead to implementation of dengue vaccine programs in other countries with a high dengue burden. For shared decision-making, it would allow for a quicker but probably limited use of the vaccine. And in theory, it would allow for more careful discussion between providers and parents. It could lead to a full recommendation later after vaccine gains are more acceptable, but it does place the burden on providers, leading to delays and maybe missed opportunities for testing and vaccination. And this path may be a dead end for this vaccine and for any other unbalanced dengue vaccines that can still provide a benefit to a group of the population. In terms of health equity, the work group considered that a routine recommendation would increase health equity, and shared decision-making likely decrease health equity, since only empowered and informed patients or those served by informed doctors would have access to the vaccine. And the administrative hurdles and the cost could reduce access for families with low medical literacy and economic means. For education of providers and families, with a routine recommendation, educational materials and training or providers would be more readily available. And for shared decision-making, there would be efforts from CDC on educating providers and patients, but we were worried about less buy-in from the health department. For cost effectiveness, for a routine recommendation that would achieve higher coverage, it seems that the strategy would be cost effective in most scenarios. With shared decision-making and very low coverage, it would likely not be cost effective. So in terms of communication and media, under a routine recommendation, communication would fall to the health department and to CDC. And something that would need to be explained is that hospitalizations among children with a history of vaccination will be mainly due to vaccine breakthrough, and a small percentage will be vaccine-induced. But clinicians and the public could attribute all hospitalizations to the vaccine. So a communication campaign would need to explain this difference. And a risk is that faulty implementation could lead to negative perception of dengue vaccines and vaccines in general. And this is a particular concern during efforts to achieve high coverage for COVID vaccines. With shared decision-making, there would be slow implementation and limited coverage that would make public relations issues less likely, and vaccine safety concerns may vary by individual, so that shared decision-making would lessen fears that the vaccine will become controversial and a stimulus to vaccine hesitancy. So in summary, the option 2, shared decision-making, we consider the cons as lower uptake, little progress in sorting out feasibility, coverage of tests by insurance companies more challenging, that it could lead to an increase in health inequities and less buying for large education and communication campaigns. And the pro is that it would lessen fears that the vaccine will become controversial and result in increased vaccine hesitancy. And for option 3, that is a routine recommendation, the cons are as I mentioned, the perception that all hospitalization among vaccinees are related to the vaccine, while most hospitalizations are actually due to vaccine breakthrough. There could be media backlash that could reduce coverage for other vaccines if that is not managed appropriately. In terms of the pros, it's a useful vaccine for seropositives in a moment where sustainable vector control for Aedes aegypti is still years off in the United States, and dengue outbreaks continue to occur. We could achieve greater coverage and reduction in hospitalizations, better buying from health departments and immunization programs to resolve the challenges with feasibility, a broader communication and media campaign, and an increase in health equity. So the work group considered that the policy option to recommend to ACIP is ACIP recommends the intervention. And this is the draft recommendation. ACIP recommends 3 doses of Benvaxia administered in persons 9 to 16 years of age with laboratory confirmation of previous dengue infection and living in endemic areas. And I'm happy to answer any additional questions.
Just a minute while I pull up my list.
Veronica.
Ms. McNally.
Thank you. I just wanted to comment that from the consumer perspective, the health equity issue around shared clinical decision-making that Dr. Paz-Bailey noted is significant for me. I worry about medical literacy, and I'm concerned that a shared clinical decision-making recommendation would mean that some children who are candidates would be missed because a provider may not raise the issue, which would be consistent potentially with CDC guidance that it is up to the provider to raise the issue, and the parent may not know to ask. And I would also note that because dengue is a significant public health problem and 75% of parents said that they were interested in having their children vaccinated, I don't think that a routine recommendation, I guess I want to say that I think that a shared clinical decision-making is not appropriate, and that a routine recommendation would be more appropriate under these circumstances. Thank you.
Any other comments from the liaisons? I'm not seeing any.
Gabriela, this is Amanda. Could you talk a little bit more about the insurance company discussions that were had, and were they specific to companies? Were they specific in state or in Puerto Rico? Was it the Puerto Rico Medicaid program versus the overall Medicaid program, and similar for the insurance companies? And then I don't know if anyone from AHIP has any comment, but to not provide the test would be inconsistent with the way that insurance companies typically are required to provide the vaccine for shared clinical decision making. So it seems in discordant with how insurance companies cover shared clinical decision making.
Mm-hmm. Yes, thank you for that question, Amanda. So we had one meeting with the large insurance companies, and we had representation from maybe 4 or 5 of the large insurance companies to explain sort of the details of this vaccine and how testing before vaccination was needed. And, we didn't know if insurance companies would be willing to actually provide coverage for that test. And the response was very positive, that if the vaccine was recommended, they would favor preventive strategies, and that they would cover for the test. We did specifically ask them for shared decision-making if that would make a difference. And what some of the insurance companies responded that they had to, meet with their board and decide once their recommendation was out. But I remember specifically about one of the companies that mentioned that in some situations similar to this, they require some documentation from the provider that the test is indicated. So that would mean that to get reimbursed for the cost of the test, that the insured person would need to show some sort of letter from the provider that says this test is needed so that we can assess eligibility for a dengue vaccine, for example. But I want to clarify that was, one meeting and that what we agreed to do was to revisit the issue once an ACIP recommendation had been decided upon. And then regarding Medicaid, we met with the group managing Medicaid for Puerto Rico. And the discussion there was if the cost of the test would be low enough that they could cover it with their current work plan, or if they needed to submit sort of a request for an amendment on the amount of funds and how these funds are spent based on the estimated cost of the test. So we provided information on the size of the population of children 9 to 16, the cost of the test that we received from Sanofi, that they estimated that it was going to be between $5 to $10, and then the frequency of testing every 2 years. And they again thought that the cost of the test would be covered, and they were just going to assess this issue about could they cover it with their current plans, and will get back to us. So it's very preliminary discussions, but it was just helpful to know that they were in favor of covering the cost of the test.
Thanks so much. That's really helpful.
Dr. Sanchez?
Thank you. No, and thank you. This was a really informative presentation. And really, I think that if we feel that the vaccine is effective and safe, I think that the work group recommendation is how I would favor, rather than a shared decision making, when to me it's kind of like equivocal. So I very much agree with the recommendation. But I guess my question and my issue is that it really ultimately will depend on the comfort level that we have with the assay that is testing these children. And not knowing how many different ones there are, is that something that would also be included to say that there's some preferred tests, or that there's some tests that, will there be some comment, not just that, and you can just test with whatever assay is available, or are you going to be able to say that certain ones are preferred because the specificity is significant, is what we want, which would be greater than 98%.
Yes, Dr. Sanchez. So the discussions that we have had with the work group is that we would stay away from recommending particular brands and specific tests, but that we would provide recommendations on the performance of the test so that health departments can regulate which tests are used for pre-vaccination screening, and also clinicians have an idea on what should be that optimal performance. That is what I shared in the presentation. And we have, it may not seem like it, but we have really come a long way. The tests that were available to detect IgG had almost 100% cross-reactivity with Zika, which is a problem in an area like Puerto Rico where Zika has circulated, and in most of Latin America where both flaviviruses have circulated. So being able to identify these tests that have a high specificity is a really important development. And the hope is that, right now it's only 2 versions of a rapid test and the ELISA test, but that more tests are going to be developed and available for pre-vaccination screening. But just let me know if I answer your question. What we're proposing is to have a paragraph in the MMWR that will accompany the recommendations that will spell out the minimum sensitivity and specificity, and sort of stay away from naming specific tests.
Now that does answer it, but I think for the practicing physician, just with any other assays, oftentimes they're so different, in getting to the actual value is critical. And I think with this vaccine, it's going to be critical that they know the source and look at the source. And so I think a lot of education there's going to have to be done.
So this is Jose here. So could the CDC have on their website a table of the tests and the most recommended tests, so that the physicians could go and look there to find it? Would that be acceptable?
So for previous testing recommendations, again, we have stayed away from mentioning specific tests, but I sort of understand what the concern is, and we would need to discuss it within the division and what we can do about it. But I agree that just general guidance for providers on it has to be this level of specificity is not helpful if they don't have an independent source saying this is the performance of the test, and only have the sort of the package insert to make decisions on. So yes, I think this is an important point, and we would need to discuss it internally on how we can provide this information to the public. And the only thing is that in the context of Puerto Rico and the regulations of who can do testing, the test is mainly going to be performed in reference labs. So there is room for the health department to regulate and say, this specific test is the one that has to be used for pre-vaccination screening and not the other test, because the tests available in the market do have a sort of a wide range of performance. So I think for the most part, the test is likely to be done in a laboratory, and the health department will have more room to regulate.
I think that would be acceptable if the health department takes the lead on that. Let me just make one comment also. So, I was originally, as I looked at your data, listened to your presentation, leaning towards a shared clinical decision making. But what really swayed my opinion that we should probably make a recommendation is the argument about health literacy. And I looked it up quickly, but about 60% of all children in Puerto Rico live below the poverty level, and that is associated with lack of health literacy in the parents. So I think that for that reason, and also going along dovetailing what was said by Ms. McNally, I mean, I think that a shared clinical decision wouldn't be the best for informing how to use this vaccine. So I'll stop there and ask Dr. Bernstein to make his comments or questions.
Yeah, thank you. I certainly was wondering what living in endemic areas, how that's defined. Is there a large segment of the population in the continental United States that goes back and forth and lives in the continental United States and back to Puerto Rico with family? That would be, and therefore children should also be eligible for this vaccine?
Yeah, so in terms of defining endemic areas, we have used the definition from the Yellow Book, that is evidence of more than 10 dengue cases in at least 3 years in the previous 10 years. So,
yeah, no, I'm sorry, I did not articulate well. I meant the living part of it. It's not. Are there people that live in Puerto Rico part of the year and live in the continental United States another part, and would those children then be eligible for this vaccine?
Yes, there is a lot of travel from Puerto Rico to the mainland, and we are implementing a cohort study in southern Puerto Rico, and we sort of know that a large percent of families left after the hurricane and then left after the earthquakes. It's hard to say how much they go back and forth, and I think that clinicians in Puerto Rico would need to make part of that decision. And, you know, a definition for living in endemic areas, like spending, I don't know, 6 months of the year in Puerto Rico, is not something that we have actually defined. So I think it's an area where we would need to think some more. If we leave it up to the doctors to decide if someone could receive the vaccine if they spend some of the time, or if we want to be more prescriptive and actually define living in endemic areas. But the vaccine is not, as part of the FDA license, it is not licensed for travelers. So people who mainly live in the continental US and travel to endemic areas, I wouldn't be covered with the current indication. I think that would be the next step to consider. What is the seroprevalence of the population that is originally from endemic areas but now lives in Florida and New York and other places, and would they benefit from this vaccine if they go back and forth to endemic areas?
Exactly.
But it's still a lot of work to do there.
Exactly. Thank you.
Thank you, Dr. Paling.
Thank you. So I wanted to dovetail on your comment and then make one additional comment. So first of all, the work group had a lot of conversations about where do we fit. We came to the conclusion that the benefits probably exceeded the harms, and so we wanted a recommendation. The shared decision-making versus a full recommendation was the point of discussion for multiple meetings. And I was one of those who was originally on the shared decision-making spectrum, and it was the health equity for me too that really pushed me towards the other perspective. The other thing that I found that was really important is when we looked at the data that Dr. Paz-Bailey presented, the estimates in the children that we're talking about, remember the FDA is licensed for children 9 to 16 years, that's why that age group. In 2007, 2011, and 2018, there are 3 different estimates of the prevalence, and they all are right around just over 50%. And so there's consistency there, which also was a very important component for me. Thank you.
Thank you. Dr. Maldonado.
Thank you, Dr. Romero. I really do believe that Dengvaxia is an important vaccination strategy for our high-risk children in high prevalence areas. And I think the data have been so much improved over the last few years. But personally, and actually in speaking to some of my colleagues through the American Academy of Pediatrics, we are not comfortable with the decision-making at this point, given that there are so many unknowns regarding the actual implementation of this really important vaccine for a very specific population in an area that's already been having issues around confidence. Remember the Zika issues that came up a few years ago, and high risk for social vulnerability. And specifically, my concerns are around really explicit and granular guidance around how this vaccine would be implemented, when screening would take place, so that is every 2 years or every year, or what will happen to track people who have seroconverted and then may need the vaccine later. And specifically, the other major thing which has been an issue is the test. And the fact that it sounds like there isn't really any thought right now to how to even develop a specific set of tests, or how to implement them, or who to recommend them. It just seems like it's really very vague and uncomfortable. And I think especially in a high-risk population, we need to be extremely granular and directed about who and what and where. And then finally, the issues around payment and reimbursement and any cost differential that will happen in these populations is going to be a problem as well. So I think this is a great vaccine. There are some issues that could be dealt with, but I'm not feeling that they are actually ready to be moved on at this point. And I'm really uncomfortable with, at least on behalf of the pediatricians in the community that we serve, in thinking that this is ready for prime time.
Thank you so much for your thoughts, Dr. Maldonado. And I think that we have come a long way in terms of understanding sort of the challenges with implementation and how we can see it being feasible. And maybe I was not able to communicate it well, and we could provide additional detail during the June meeting. And I agree with you that we don't have all the answers right now, but that some of these questions will be answered when we are actually sort of, implementing the vaccine. I think the coverage of the test has been addressed by insurance companies saying that they would cover it if there is a recommendation. We do have the issue of the test not being FDA approved and the fact that they would be implemented under CLIA, and sort of the additional work the labs would need to do for that. But we know that they have experience specifically with tests for arboviruses because they're not as important as prevalent in the continental United States, so they have had to work with tests that are not FDA approved, but they implement under CLIA, and they have done this for chikungunya and for dengue tests. So the labs that we have spoken to think that they could implement it that way. But we can, put together more detailed information on this implementation issue so that I can communicate it more clearly when we present to ACIP again in June.
Yeah, so thank you for that. I just want to add another thing. Sorry for speaking up again, but so I do think that, having to recommend implementation is not the role, or I think it does not necessarily need to be the role of ACIP, but I do think in this situation, if you could give more guidance and much more prescriptive guidance, that would really be helpful. And I think in particular around the tests, maybe, for example, not naming tests, or if you wanted to, I guess that's fine, but at least saying it has to have X degree of specificity. I think the specificity issue is just going to be really the deal breaker for looking at the ICER calculations. And so if there are creative ways of doing that between now and June, that would really be helpful.
So this is Jose. Let me just say here, so Dr. Paz-Bailey, you anticipated in part the specific recommendation that I was going to make, that at the next meeting, could the health department please present to the ACIP as detailed an implementation plan as possible? And I'm going to ask that you take that back and see if you can bring that to us. And let me also, I still think, in contradiction to what Dr. Maldonado is saying, I think you're going to have to provide specifics about what tests to be used, because physicians don't have the time to go look to see if their reference laboratories have a specificity or sensitivity that's necessary for this. And I think that naming specific tests would be more helpful to physician. And I don't mean to contradict you, Dr. Maldonado. Dr. Paling.
Okay, so first of all, I want to say thank you. This has been a robust conversation and is really important. And one of the things I think I want to go back to is that dengue is an important cause of morbidity and mortality in endemic areas like Puerto Rico. And there is no treatment. It's supportive care. And children 9 to 16 years of age have the highest prevalence of hospitalization and severe disease. And there currently is an outbreak that began in 2000 with 1,000 cases. So this is really important. At the last meeting, we presented 3 cases, 3 of the tests that meet the criteria, and there is going to be specific sensitivity, specificity, positive and negative predictive values in there. And this is where we're going to need to really think carefully, because when in this scenario, it's likely additional tests would come. So where do you put those, because you want to include additional tests? We do need to remember that in Puerto Rico, clinicians' offices are not allowed to do the test. They're all mandated to go through very specific laboratory processes. And so the health department has the ability to significantly control this. We also know that to get through the full granularity of implementation, you need to be actually having a clear that you're going to be using it. Otherwise, it's an exercise in futility. And so this is the delicate balance that we're all going to have to manage. And so I just wanted to provide those clarity, and this has been the source of many discussions throughout the work group. Thank you.
Thank you. Dr. Hayes.
Carol Hayes, the American College of Nurse Midwives. I have a recollection that there is a precedent for CDC recommending certain tests, and it was from back in the 90s when HIV tests were first commercial HIV tests were coming on the market. And so I'm going to challenge you to do a historical review of the MMWRs back in the 90s and see if you can find that recommendation. Thank you.
Thank you. Ms. Bata.
Yes, I'm kind of jumping off of what Dr. Paling had said and what was suggested in terms of hearing a little bit more about implementation. And I'm trying to imagine implementation within the provider community in these endemic areas, and what might be different and what might be similar to what we see within our own infrastructure for healthcare. The implementation might be different enough that, and dengue is familiar enough to clinicians that might be less of an issue. So just a thought. And I can't remember if a survey was presented related to clinicians. I know we heard some surveys about the parents, but I can't remember what we've heard about the clinicians who service these communities. Thank you.
Yes, thank you for that comment, Ms. Bata. And just to talk a little bit more about how this could look in practice is, a child goes to their primary healthcare doctor or his or her pediatrician, and if they're in the eligible age, that pediatrician will have to order a dengue test. And then based on the results of that test, if the child is positive, then they would go to a vaccination center that in many cases are not in the pediatrician's office. In a few cases there are, but in most vaccinations are managed in sort of specific vaccination centers. And then with that positive result, they would receive their vaccination dose. And we can provide, more clarity on that sequence. I think what we have learned with COVID is that a test can be ordered by text or by email. The result from the lab can be received by text or by email. And there are ways that we can reduce the number of visits that would be required for this process to be completed. Regarding the question on the provider's side of things and what we know about it, we did conduct a survey among pediatricians, and overwhelmingly they consider dengue to be a public health problem in Puerto Rico. Only half were aware about Dengvaxia having been approved by FDA, so education does need to happen to increase that percentage. And when the process was explained that a test would be needed before vaccination, about 70% of the providers said that they would recommend Dengvaxia to their patients. So we have done this survey among about 100 providers and have learned about their attitude towards the vaccine.
Dr. Cohen, do you wish to make a comment?
Yeah, thanks, Gabriela. I was also just going to recommend, as part of what is presented in June, if you would also just talk a little bit more about the post-implementation safety monitoring and how, I know you talked a little bit about VAERS, but I think that connecting the test to the vaccination and then somehow or another making sure that your systems are talking and you can have all the information on your future dengue cases on if they had received the vaccine and if they had had a documented test would be really helpful. I think you guys have probably already been thinking about that, but we certainly from COVID, it's been also clear that demonstrating strong safety surveillance post-implementation has been incredibly helpful from a confidence perspective.
Yes, thank you. Thank you, Amanda.
Are there any other comments or questions from the voting members or from the liaisons? Any of the ex officios wish to make a comment? Not seeing any, so thank you very much. Dr. Paz-Bailey, thank you again for these presentations and for taking all of our questions and suggestions. I believe you've handled them exceptionally well. Do you have any other announcements, Dr. Cole?
No, if we are ready to close the meeting, I would also just congratulate and thank all of the presenters today are doing all of this work amidst all of the other COVID and other related urgent activities. And so these were really, was really extraordinary work today and off cycle for our ACIP meetings. And we appreciate everyone's time once again, giving us additional time to help us get caught up in these discussions so we can keep moving with our recommendations. I do just want to remind everybody that we do have a scheduled emergency ACIP meeting. I will have to look to Stephanie to remember the number that this will be, but it's more than 10th, on Wednesday, May 12th, right. Beginning at 11 a.m. Eastern Standard Time, and we will have an agenda up for that meeting shortly. Thank you very much. And public comment will also be available to sign up for that meeting shortly.
Yep, as of tonight. So public comment will be up tonight then. Close of business. Thank you. All right, if there is nothing else, then I will knuckle, since I don't have a gavel, this meeting to a close. Thank you all again, and let me echo Dr. Cohen's statement on thank you for the amount of time that you have spent on this and other issues. Thank you again. Good night.